a physical medicine and rehabilitation specialist. He is the director of neurorehabilitation, translational research, and clinical one at Fondazione Santa Lucia in Rome. The department integrates neuroscience research and clinical neurological rehabilitation units. The clinical unit is devoted to rehabilitation of patients with brain or spinal cord lesion in a multidisciplinary environment. Research activity has been always focused on brain plasticity mechanisms and functional recovery, both at basic science and clinical levels. Basic science approaches in animal models, as well as development and testing of new neurorehabilitation technologies in humans, characterize Dr. Molinari research experience. In the last decade, research activities mostly focused on human-machine interactions applied to neurological rehabilitation. Dr. Molinari is author of over 250 articles published on indexed journals. The Web of Science H index of Dr. Molinari is 56, and he is a review editor of the Cerebellum journal. It's my great privilege to give the floor to Dr. Molinari for his lecture entitled Robotics in Clinical Setting for Spinal Cord Rehabilitation. Marco, please, the floor is yours.
Thank you, Stefano. And thank you, Professor Zollo, for inviting me for this presentation. Is everything fine with the presentation? Because I still see
we see you, but we don't see the slides, Marco.
Exactly, that was my...
You should share. You see the button, the red arrow.
But, okay, is here.
On the bottom of the screen. Now,
is that okay?
Yeah.
Okay, fine.
We are starting, yeah.
Yeah, well, we are always learning new conditions and new approaches. Also for a presentation. My presentation will be a little shift from that of Stefano, in which we just move from the lab to the clinics. And we move from the clinics to the lab. Instead, the other way around was Stefano presented, let's say from research to the application in neurological rehabilitation. The main idea of say about human-robot interaction, in this case, I would like to make a joke and say that it's a therapist-robot interaction. So what is the capacity of the clinical system, of the clinical world to accept robotics and to accept new technologies in rehabilitation? As this is a puzzle slide with many different aspects of Santa Lucia activity, neurological rehabilitation are presented, but just to focus that as it should be, everything is patient-centered. So it starts from the need of the patient, and we're trying to provide the answers to the different needs that arise from neurological lesions and from the functional impairment that are a consequence of this brain or spinal cord lesions. Stefano presented a number of devices that have been developed in research and that are available on the market. There are very many. Of course, every single clinical ward cannot have all the devices available. But at Santa Lucia, at least in the department I direct, there is quite a number of technology, both devoted to balance rehabilitation with force platforms for balance, even in different devices that can be used standing or even sitting, that can provide evaluation and training. We have different devices for the upper limb with system with sensors that allow to trace movements like the Pablo or the Chimea, exoskeleton like the Armeo Power, or system based on BCI that we'll talk more in depth later on, like the promoter, or different exoskeleton for lower limb. Like one of the answers of Stefano was that the choice was made mainly about availability. In my department, we have some very old exoskeleton, like the Argo, based only on springs. We have both end effector, like the gang trainer, and exoskeleton with body weight support, like the Locomat. We have different ambulatory exoskeleton, some derived from research that are not or regular clinical use, but some others that are commercially available, like the Rewalk and the Exo. So we have all this toolkit that is available for rehabilitation in the world. But that doesn't translate automatically in their use. You can see here is a graph that follows that progressive from 2015 till 2018, the number of sessions made with technological support in the clinic. And you can see that the percentage has been very, very low for many years. So the availability itself doesn't mean that it's been used in a regular clinical setting. After recording this, let's say, failure of the impact of all these technologies that were available for physiotherapists and doctors, we employ a more aggressive strategy with specific training for the physiotherapists, for the doctors, with condivision of experience about the use and about the indication. You must say that all these technologies come to the clinics with very little information about their use. Say use for recovery of arm or gait function in stroke or spinal cord patient. Which type of patient? Which moment of the rehabilitation curve? Subacute or chronic? Is all something that a clinician have to learn directly hand in hand with trial and error strategies. That is not really the best when you are dealing with patients in a very critical moment like the subacute phase or a stroke or a spinal cord injury. Actually, with all this training and experience, now the number is quite increased, and we are providing with technology about 30% of all the treatments provided by the unit. This is not really achieved naturally. It's been achieved through a really an effort that is been quite strong, and this continues. You must say that you must remind that physiotherapists, like doctors, change. The technology change. You have to keep an training and sharing of information continuously to allow this technology to be applied directly in clinic. It's quite difficult that someone that has been for 20 or 30 years in the business, not using technology, suddenly start using exoskeleton or end effector system or virtual reality or new technologies, especially if they not a specific instruction for the use and indication. Look how many information you get for the new drug. There is not a shadow of this information when a new technology just appear in the rehabilitation department. This is really a gap that we have tried to fill up. Furthermore, let's focus more specifically on the rehabilitation in spinal cord injury. And mainly, I will focus in this presentation on the gait rehabilitation. Of course, there is a first real clinical segregation about the expectancy if we have a motor complete or a motor incomplete lesion. If the lesion is a motor complete, the possibility of functional recovery of the use of the lower limb is almost absent. And so the focus of rehabilitation is mainly to acquire the capacity to be dealing with the activity of daily life on a wheelchair, increasing the strength of the upper limbs, the control of the trunk, the balance of the trunk, and eventually the use of substitution of gait with exoskeleton. That is quite different from training gait that we'll see afterwards. In this, the help of technologies is limited, although is important. For instance, for the improvement of trunk control is not really significantly different from traditional approach, but it can be done alone without the assistance of a physiotherapist, and it can be done at home. So it can be quite useful for keeping up strength and balance in a therapeutic framework that is quite limited. With chronic spinal cord injury patients, at least in Italy, the assistance and the capacity to do training and the support of the national care system is very limited. So everything that can be done alone without with a reduction of cost and with only a supervision, occasionally supervision of MDs or physiotherapists is of course welcome. And finally, the assistive exoskeleton, like the rework on the exo. They has been in the market for quite a long time. Actually, their clinical use is very limited and their functionality is really no match for the functionality of a wheelchair. Still a lot of work has to be done before an exoskeleton can compete in the ease of use and the ability to affect the activity of daily life compared to the improvement you can have with a good use of a wheelchair. A different argument is going to be on for motor incomplete. For a long time, the assistance of gait recovery or motor complete subject has been very limited. Although the exoskeleton, like the Locomat, has been first developed with the idea of supporting the functional recovery of central pattern generator in the spinal cord after spinal cord unit, that objective actually remain real far to be achieved, and the support that exoskeleton can be do with functional recovery or gait is mainly on stroke patients and very limited on spinal cord. Although the capacity to interact with technologies with spinal cord recovery seems to be improving as long as we can adapt the specific effect of the technology to the needs of the patients. And in this aspect, the human-robot interaction became quite critical. I would say just to focus more than human to patient robot interaction, meaning that the interaction must be able to realize what are the rehabilitation needs of the patient and to provide answer to this. It's not simple that there is an interaction on the control system, on the capacity of the user to control the activity of the exoskeleton. It's very important that the exoskeleton, or better, the technology, is able to read the needs and the changing needs of the patient and can provide correct answers. Let's start with the traditional approach of gait rehabilitation in spinal cord. Usually the patients in a subacute phase arrive in the nerve rehabilitation ward of the spinal center in bed. Has not yet regained the sitting position. And first is the mobility approach and regaining of the sitting position as soon as possible. After this is achieved a control of the trunk. If possible, start the sit to standing, the standing position with support, the walking between bars, walking with some type of aids like cranes or walker, free walking, stairs, and outdoor walking. This is the hopeful course of patient with complete motor lesion, mostly with ASIA-D, that is the subject was impairment of the muscle below the lesion that is at 50% with normal strength, or patients with quite peripheral lesion in which the proximal control of the proximal muscle of the lower limbs is still quite good, and thus with some type of device that can support ankle, they can achieve quite functional movement. In this framework, the application of technologies is not uniform. There is one of the statements I followed from Professor Mazzoleni was the idea that we are looking for the right patients for the right robots. Actually, the right patient for the right robots is quite a challenge because patients change. The same patient at different phase of recovery might have quite different needs that can be answered by different technologies. And so theoretically, you should have a shelf with all the technologies available and be able to diagnose at a certain point, which is the technologies right for that patient. For instance, in this phase, when there is track control, the sensorized platform like the TIMO that can be used sitting is used in clinic quite regularly for improving the capacity of the patient to perceive the correct position of the trunk. The same platform used also later on if or when the patient reach a standing position and has to perceive the correct position of the weight, often when there is also a missing of the sensory and proprioception. So the capacity to feel the position of the leg, to feel how much weight is put on the different side is quite important. And beside the indication of the physiotherapist, the idea that it can provide a direct feedback, precise feedback of the different weight that is put on the different legs is quite important and can be of advantage. Similarly, at the other type of platform beside the TIMO, of course, can be used. And at this point, when there is a certain part of trunk control or even earlier, but that is an indication that is impaired by the possibility of having difficulty in blood pressure control. And so the standing position with the body weight support has to be considered carefully. They can be trained with body weight support system and exoskeleton. I must say that, as I showed before, we have the availability of both exoskeleton and end effector, but because of the difficulty of controlling the position of the knee with the end effector, at least for spinal cord patients, the use of the end effector mechatronic is really limited, at least in our experience. And that is, at least for our experience, the use of the end effector for the gait rehabilitation. As the standing position is achieved, as I say, the other platform can be used for trunk control and still working with the capacity of improving gait using exoskeleton, but also using the functional electrical stimulation that associated with the cyclic movement of the cyclofess is used quite routinely and quite effective in controlling spasticity, much less in improving strength. But for controlling spasticity, both the gait on locomat and the cyclofess are quite important. The use of ambulatory exoskeleton like the EXO is more limited. Is more limited. Why? Because first, there is the need of a constant assistance from the physiotherapist and risk of falling. Risk of falling that is not present with the locomat. The locomat also requires the presence of the physiotherapist, but effort needed are very reduced. You consider something that is not often reported in experimental studies on exoskeleton, that you have also to compare the biometrics of the patient and of the physiotherapist. You might have a patient that is 190, 2 meters, and the physiotherapist that is a gentle female of 160 or 170, and has to hold the body with this handle on the back of the EXO in case of difficulty in balance. And you can see how that is the risk. And you cannot always match the biometrics of the patients with the biometrics of the physiotherapist. And this is another quite important difficulties for the regular impact of this exoskeleton in clinical trials. So this is the cartoons that illustrate the regular traditional training of patients with gait impairments, and the fact that in introducing technologies is not to consider only the interaction between the patients and the exoskeleton, the technology, but also the use and the capacity to understand mechanisms and to interact by MDs and physiotherapists. This refers to a comparison directly between the, say, the traditional rehabilitation and the technology. One important thing is that the physiotherapist throughout the development of the recovery is able to adapt. It's always the same physiotherapist that is interacting with the patient, that is adapting his activity to the changing needs of the patients. This capacity is not a specific metrics like our friends engineers will say, but is very adaptable. And the clinical history and experience of the physiotherapist is critical in producing a therapist that match every time the needs of the patient, not only day by day, but also within the same session. You can imagine that the spasticity or rigidity of a limb changes according to the therapy that is produced, and thus the exercise has to be changed. And this plasticity of the approach that is present when a good traditional rehabilitation is applied is not always the case when a robotic or technology is applied. Some of the aspects of robotic assisted gait training, like the intensity and repeatability of the training that often are considered as a plus of the system, can be at the same time a drawback, because it's not really clear how much strength can be imposed on a subject and how much the repeatability, the fixed type of movement may be useful. I think that this lack of adaptability of the machine to the needs of the patient may be one of the main reasons why we have so little demonstration of the clinical efficacy of this approach. Anyway, if you look at the tool list, you can see that many of different aspects that there are drawbacks on one side. For instance, for the lack of repeatability, we don't really know what a physiotherapist is doing in a session. And we leave this to the experience of the physiotherapist. can be helped by the introduction of technologies that improve the capacity of scoring the condition of the movement or recordings the effects of the therapy. On the other side, when we have application of technologies or robotic, reduce the rigidity of the system and applying a more adaptability, and especially to introduce some type of reading of the physiological, neurophysiological, and clinical needs of the patients might be very critical in improving the efficacy of these approaches. So we have a number of different technologies, and I will say before, and we still don't have exactly what are the indications, why I should use the balance SD just for saying, or the TIMO for improving balance, or even the quite advanced rehabilitation device that is the float, that is a system only with body weight support that allowed ground walking with no assistance of exoskeleton or head effector robotics. And again, for gait rehabilitation, when I should use, I would say, the end effector, the locomat, the exo, or the rewalk. This is, again, something that has to go back to the different condition of the patient throughout its recovery. Of course, not all patients reach all these stages of recovery. They might stop their recovery at one of these stages, but it's important to focus that the ability of the availability of different technologies allowed to cope with the different needs in the different stages. And these are examples of the exoskeleton and mainly the locomat. I don't think that we really need to be in depth with this, just to say that one of the main problems with the locomat is the lack of assistance of the ankle, why only knee and hip are assisted. And in many cases, there is a problem mainly focusing on ankle control. And for instance, in some time, this is assisted with technology with the use of electrical stimulation assistive device like the walk aid. This is the end effector device. The gang trainer, as I say, is, at least for spinal cord injury, is used only rarely, mainly because of the lack of assistance of the knee. And I must say that the assistance that can be provided by the locomotor is more complete. The attention of the physiotherapist is reduced, and the capacity of the patient to interact with the machine better with the exoskeleton than with the end effector. So the different device again, with body weight support, without body weight support, without exoskeleton, and this interaction also with other systems like the face assisted device, or the use of other support for the needs. So, getting again to the different schema about the motor incomplete or the motor completed, a different type of use of technologies, I want to get you to a very specific clinical case in which a subject with a traumatic lesion at 39 years with lesion at the C4 and one is a grade D. That means that there's a strength of the limbs of the muscle below the lesion, 50% were affected and 50% has a quite normal strength. And during the different period, there has been in our department between October and March. And at the beginning, when he was still in bed, he started using the FES, functional electrical stimulation with the cyclo-FES for the lower limb to reduce spasticity. Quite early has been training with a locomote. There's also been an attempt to use the float as soon as he was able to manage a little standing, but the approach with the float was reduced in time because it was unable to improve while the locomotive training continued. And at certain point, let's say between January and February, was also introduced the assistance of the FES for the upper limb to reduce the insurgence of spasticity of the upper limb. You have to remind that this was a cervical level patients. And at the end, with the good recovery of gait, was supported the dorsiflexion of the ankle with the use of the electrical stimulation assisted walk aid. So you can see that it's not only one technology. The technology is mixed up according to the different time and for the changing needs of the patients. So if something is getting out of this pluridimensional experience, is that we have still to move to a very personalized robotic rehabilitation. We cannot start with a device developed without taking into account which are the needs of the patients. We have to try to develop technology that specifically answer to the needs of the patients. In this line, as I was saying at the beginning of this talk, we have to somehow change the type of approach, not starting from the research, but starting from the needs of the patients. This is a recent paper from my group. First name is Federica Tamburella, in which we published the results of a EU-funded study of quite some time ago, in which we tested the effects of changing the feedback information to the patient while using locomote, and this was done in stroke patients. Most of you should know that there are some feedback already provided by Okoma. When you're using locomote, they are mostly navigational tasks or information about the compliance of the patient to follow the movement of the exoskeleton. With the help of Donatella Mattia, Febo Cincotti, and Jose Pons, CSIC in Madrid, that was a leader of this better project, we developed a system in which electromyographic information about the activation of the muscle was provided to the patients, and this was provided online. Here you see that while the patient was moving, there is these bars were changing colors, showing if there was low activation, blue, or hyperactivation of proximal of distant muscle of the limbs, and was requested to the patient to adapt, to keep the bars white, nor red, nor blue. And this was in a crossover paradigm in which the same patient were first trained or were trained either with locomote with the usual feedback or the locomote with this ad hoc developed feedback. And nicely, only this approach, with only 2 weeks in a crossover paradigm, were able to demonstrate a significant effect on clinical scale if the feedback was provided in giving information about specifically the muscle activation. That seemed to us to demonstrate that the top-down approach, the involvement of the patient, or better, the capacity of the patient to correctly interact with the movement of the exoskeleton is critical to change the efficacy of the treatment. This is results from another EU-funded project, Simbitron, that was coordinated by Herman van der Kooi of the University of Twente, in which since the beginning, this type was in spinal cord injury patient, we have a subject with spinal cord injury, chronic ones, involved directly since the beginning of the study to the development of a new exoskeleton. The idea was mainly to develop an exoskeleton specifically for each one of these participants, according to the specific needs of the patients. Actually, we really didn't succeed in developing in 9 different exoskeletons, but we developed a modular exoskeleton that can be only with ankle, and knee, or hip, ankle, and knee. And with the collaboration of a PFL, was developed a control system, was defined a neuromuscular control, in which the adaptation to the kinematics of the exoskeleton was tailored to the specific patient, exactly to the beginning 3 or 4 steps of the patient to adapt to the needs and the requirement effort of the patients. Again, on this patient-machine interaction, this is an ongoing project that is coordinated by CSIC in Madrid, is Eurobench, is the development of a benchmarking European system for bipedal locomotion and exoskeleton, in which Yolanda Pisotta and Nevio Tagliamonte are providing tools for the acceptance, the acceptability, the experience directly of the subject, using the user of the exoskeleton, forgive me for the grossolanity of the term, as a sensor to validate the capacity of the exoskeleton to answer to the needs of the patients. In this, there is a mix of neuropsychological testing and sensor that can acquire the psychological and mental status of the patient while using the exoskeleton. This is a way to move toward that psychological aspect that Mazzoleni was speaking before, and to try to have a benchmarking in which everyone that is developing an exoskeleton for locomotion can apply to these tools that are available for free in this structure developed in Madrid. And now another critical aspect to conclude my talk, that is the medical therapist interaction with the exoskeleton. And in this, as I was saying, until now we have talked about the patients, but as I was saying, we have also to consider the doctor and the physiotherapist. One of this, in this link, I would call it like the brain-computer interface proposal, is a project that is going on now for many years in Santa Lucia, mainly driven by the activity by Donatella Mattia and different collaboration within the institution. For those who are not well aware of, the brain-computer interface is an approach that now is going on for decades, in which mainly developed to connect the brain or someone that has difficulty to interact with the environment with a computer, so he can interact with the environment. He can write, he can use domotic device by changing in brain activity. This is usually the traditional approach of the BCI. So you record with the EEG brain activity, and then you extract to an algorithm command to replace, restore, enhance, supplement or improve different type of activity. A new idea is to change the direction of the activity and try to figure out if the BCI technology can help us in understanding what is happening in the brain when I'm doing something like the traditional physiotherapy or robotic training, I said before, with the Armeo or other device for the upper limb or during gait, lying in the locomat, or training with exoskeleton, or with mental imagery, with activity I am doing with my volition in controlling mental states and mental activities. So the idea is to find out the possibility and the strength of EEG technology mainly to discover, to guide changes in brain connectivity. If this proves feasible, then will allow the patient to control the exercise. It might help the doctor in diagnosis and prognosis and indication of the different device and treatment that can be applied, and the physiotherapy to guide his intervention. And further, if we applied this loop to the therapist and to actuators of the technology of the robotic, we can also envisage at a certain point when we have a brain network interface in which you can be used directly to adapt the activity of the robotic device, of the technology, directly to the changes and to the needs of the patients. In this line, the first step developed at Santa Lucia is the so-called promoter, in which we have a system that allows recording of brain activity during motor imaging of hand movements and a feedback that is provided through a screen of desired movement of the hand. There are no robotic device, is a video feedback, and this is the group mainly involved with led by Donatella Mattia and the group of La Sapienza of Febo Cincotti. Look now at this movie in which we show what is the training of the patient doing the robotic training. And this is a task in which is asked to close, to grasp the paretic end. And the algorithm is developed through recordings of, this is stroke patients, and is based on recordings on motor activity of the healthy hemisphere and compared to the correct recording sites and activity of the injured hemisphere. The patient is looking at a screen and is asked to think about closing the hands. The therapists look at the screen, which is the traditional feedback of the BCI it presents. This dots moves according to the capacity of the mental imagery that is doing the patient to respond to the correct condition imposed by the algorithm. And now you see that this dot is going up. And when he reaches the green bars, and if and when reaches, then the hands close, providing positive feedback to the subject. With this has been first a randomized controlled trial published in now the promoter is a CE marked device routinely present in our clinics. These are results of analysis in neurology, in which the randomized controlled trial demonstrated an efficacy in clinical scales and in connectivity indexes in the subject that were doing the motor imagery with the BCI feedback compared to subjects that were doing it without the BCI feedback. So I think this is a strong proof of the importance of this approach to demonstrate the efficacy and to be able to control the activity, at least in this case for motor imaging, but it can be easily considered, it could be enlarged in different other rehabilitation conditions to guide rehabilitation intervention. And now for a final, just a step into the future, this is a just founded young researcher grant of Italian Ministry of Health, granted to Dr. Marcella Masciullo, in which we are putting another element in the loop, mainly the physiotherapist. This is a result of a paper published a few years ago by Federica Tamburella, in which the effect of manual stretch elongation of in reducing spasticity of subject with ankle spasticity by stroke was compared between traditional stretching exercise toward the same stretching exercise potentiated by a feedback provided to the physiotherapist of the degree of spasticity through MG recordings. Only the improvement of the capacity of the physiotherapist to detect the muscular condition of the patient during the exercise significantly improve the efficacy of the treatment. So again, a strong indication that the interaction between traditional approach and technology might be very helpful. In this study that just started, the interaction of the locomat with the physiotherapist and the patient is analyzed using also hyperconnectivity studies and interaction and capacity to support the activity of the patient to interaction of the physiotherapist directly with the machine and the patient. And I hope in a few years we'll be able to answer also to this aspect and try to figure out how this triad of robotic, physiotherapists, and patients can be really improved, providing directly protocol of use for the different technologies. So tailored rehabilitation is exactly how we have to go. How much precise we can be is really an open question, but we really have to understand which metrics are we going to use and which are the main aspects that we have to focus on, not only directly the movement, but also the involvement of the patient and the involvement of the therapist and the person who applied the treatment. Let me conclude by acknowledging the contribution of all the people that works in my research labs: Federica Tamburella, Marcella Masciullo, Yolanda Pisotta, Nevio Tagliamonte, the new latest addiction, Alessandra Bigoni, Matteo Lorusso, and of course, Giorgio Scivoletto, that is the coordinator of the Spinal Cord Center here at Santa Lucia. And below there are the acknowledgements of the support we receive from different EU and national grants. Thank you for your attention. And of course,
Marco, are you there? Marco? I cannot hear you. Maybe we have lost the connection with Marco Molinari.
Yeah, I think we lost him.
Thank you, Matteo. No, because I was alone, so I was wondering if also I was losing my connection. So let's wait for reestablishing a good connection with Dr. Molinari in order to provide some. Marco, thanks a lot for reestablishing a connection. We are now open for some question from the audience, from participants at the seasonal school. There are someone, please, guys, can you proceed instead of writing? Please, you can raise the hand, and we give you the floor for presenting your question to Dr. Molinari. Okay, I see Marco. Marco, please proceed with your question.
Yeah, hi. Thank you for the inspiring presentation. My question is about the slide you presented, about the work in which you tried to develop the exoskeleton, which was driven to the subject specific need of the patient in collaboration with the University of Twente. I was wondering, the model that implemented in the exoskeleton was driven by some physiological data acquisition like EMGs or muscle tendon dynamics, or was it a software that was embedded before in the exoskeleton? Was like a real-time feedback tailored on the subject?
No. First of all, as I am an MD, so not an engineer, and this has been developed by APFL, by the group of IEEE, and ESPERT. But no, was not online, was made previous by recordings, functional recordings made is mostly on a software according to the resistance of the movements in the first step, but was driven on a model that was developed through EMG and the tendon recordings and whatsoever. But I can send you the paper that describe exactly the development of the algorithm that
could be not. Yeah, sorry before the question maybe.
But as before, I am a mere utilizer of this approach, although that it started from a strict collaboration on the recordings of the patients. These patients went to Twente and were recorded directly them in a different of settings to record disc electromyographic extension, resistance, force of the subject during gait that was used for developing the model.
Okay, thank you. If you can give me the reference, would be appreciated.
Sure. I don't know how to contact you.
Marco, you can send the paper to the organizing committee, to Matteo, and then we will forward the information to the attendees.
Perfect. I will.
Thank you very much.
Guys, there is time for another question. There is someone? If not, okay. Loredana, if you agree, I think we can say a big thank to Dr. Molinari for his inspiring talk. Thank you, Marco.
Thank you, Stefano, and thank you, Loredana.
It was a privilege to moderate this session. So I declare close this morning session. We have time for having lunch. I don't know, Loredana, if